Good afternoon, everybody, and welcome to this webinar, which is a launch of the RCR Bladder consensus statements to give you the opportunity to ask questions, to give the team the opportunity to discuss the issues and to put them into context. There are a few housekeeping points that I'd like to highlight. I would request that everybody puts themselves on mute, please, and there will be questions and answers for the second half of the hour, and if you could use the chat function for that, please. The presentations will be recorded, but the Q&As won't be recorded. So the presentations will go onto the website, but the Q&As won't, because we want to give you the opportunity to speak freely and to ask questions, and of course there are no stupid questions. And also you will get CPD points for this, and the carrot is that that's for filling in your feedback form, which will appear in your inbox as if by magic. It gives me great pleasure to introduce the team. First of all, Mohini, who's consultant clinical oncologist, and she's the chair and lead for the consensus statements, and chaired the steering group most patiently and effectively. Lydia, Dr. Lydia Makaroff, is the Chief Executive of Fight Bladder Cancer and President of the World Bladder Cancer Patient Coalition. We have had apologies from Vish, our surgeon, who is appropriately scrubbed in theatre and doesn't think he'll be able to join us, unfortunately, today. And of course, Nick James, who's Chair of Prostate and Bladder Cancer at the RCR, and also works as a clinical oncologist at the Marsden. The structure of the afternoon, well, the evening will be that Mohini will give an introduction, then Lydia will talk about patient impact, and then Nick will be talking about the role of chemoradiation, which is obviously really important in this setting. All the speakers will speak for about 7 minutes. We're happy for you to put your questions in the chat box as they speak, but then and then we'll collate all the questions and save them for the Q&A session at the end. I would just like to say some thank yous, if we could move. Thank you. So this this is familiar to you. This is the consensus statements published on the 16th of May, and I would like to. There are many people I would like to thank, but I would like to start with Mohini, who has put in hours of work. She's passionate about this subject, and I really feel that having not being a bladder cancer expert by any means at all, but sitting in, listening to the discussion, I hope that you will agree that these consensus statements really will have an impact and will help you to improve the care for your patients with bladder cancer. I would also like to say a special thanks to Sarah and Emma, who have supported us from the college. Sarah knows more about this process, which is not straightforward, than anyone I know, I think, and Emma has been a great support in terms of sending out emails, collating responses, and generally administrating all the various issues. I'm not going to go through all the acknowledgements, but you'll see on this slide and the next slide that the steering group was extensive. So thank you to everybody that was involved, including the co-opted members. Already said thank you to Emma and Sarah, the project team, and a huge thanks to the patient representatives and the nominated specialists from each radiotherapy centre who attended for the entire day on Teams for the consensus, the Bladder Consensus Day. So thank you very much to everybody. That I would like to hand you over to Mohini to give the introduction, rationale, and the overview of the consensus statements.
So I hope you can see my slides. Okay, yes, so thanks very much, Nicky. So before discussing the consensus statements, I thought I'd just spend a little bit of time discussing why we felt it was important to develop the statements. And really, the backstory to this was the RCR muscle invasive bladder cancer audit that we published back in 2018. So prior to this, the audit co-lead Sarah Treese and myself, as well as numerous members of the Urology community, felt that there was a significant case for improvement for care for our patients being diagnosed with muscle invasive bladder cancer. And the NICE statements, NICE guidance themselves highlight significant inequity with a statement that there is thought to be considerable variation across the NHS in the diagnosis and management of bladder cancer and the provision of care to people who have it. There have been publications, the meta-analysis with regards to neoadjuvant chemotherapy and several UK-led large randomized controlled trials with regards to the significant benefit of concurrent radiosensitization. But the penetrance of the treatments in day-to-day practice was unknown, and it was felt to be of value to try and to measure this. At the time of the audit, transurethral resection of the bladder tumour, TURBT, was the point at which the cancer clock stopped. This is a biopsy, and in no other cancer would it be accepted that the cancer clock stopped at the time of biopsy. There was a huge inequity with regards to this for our bladder cancer patients, but there was also very little knowledge about the time to commencing definitive treatment along the oncological pathways to starting neoadjuvant chemotherapy or concurrent radiosensitization. This data was unknown. And unfortunately, there were increasing reports initially from the National Patient Cancer Surveys of our bladder cancer patients describing very poor patient experience. So just moving on to our key findings from the audit. The median age of the patients who were measured within the audit was 78. And this demands consideration as many of the treatments we recommend are often tested within the trial setting in a younger population who may be less comorbid. And the importance of identifying an elderly age of population, average population, is that we need to really consider morbidity appropriate treatments and develop clinical trials which take this into account. And perhaps also use it as a stimulus to consider the use of geriatric assessment tools. We identified for the first time the time to commencing neoadjuvant chemotherapy was just shy of 2 months at 57 days. And if patients were not undergoing neoadjuvant chemotherapy but undergoing radical radiotherapy, they waited 82 days, a median of 82 days to commence their treatment. So with Fight Bladder Cancer taking the charge, and with other stakeholders, with BAUS and with BUG, Fight Bladder Cancer was able to use this data to canvass NHS England and that of the devolved nations to change the TURBT from definitive treatment to diagnostic tool, aligning with all other tumour sites. Encouragingly, we identified an increasing use of neoadjuvant chemotherapy, 42% of the radical population. And this is non-trial patients, this is day-to-day patients that we are seeing in our clinics. However, despite national and international guidance recommending where radiotherapy was being considered or used, the unequivocal recommendation for the use of concurrent radiosensitization, we unfortunately identified a low penetrance of concurrent radiosensitization. We also identified quite significant variation in the quality of radiotherapy and IGRT. So we felt that there was a huge case for the development of the consensus guidelines. So despite the NICE and RCR guidelines, we felt that there was significant variation in practice across the UK. And the aim of the consensus statements was to minimise the variation of care and ultimately, hopefully, improve the quality of care and outcomes for our patients. So there are 5 main topic areas for the consensus statements. The first 3, patient pathway and follow-up, systemic anti-cancer treatment, and the technical aspects of radiotherapy, divided into radical, high-dose, palliative, and palliative, were aimed at being patient-centred, trying to streamline the pathway, and also drive evidence-based medicine. So the patients, we wanted to really support complex decision-making. And having identified an elderly population, wanted teams to think about the use of comorbidity assessments and perhaps even consideration of prehabilitation as they do in the cystectomy pathway. There was a unanimous support for advocating for a named bladder cancer CNS to support patients along this pathway. We wanted to also streamline the pathway. We've demonstrated quite significant failures in doing our best by our patients along the muscle invasive bladder cancer pathway. And so within the pathway, we wanted to reiterate the need to see all relevant specialists in a timely manner. With regards to driving evidence-based medicine, we wanted to minimise the variation of practice and enhance the consideration and uptake of neoadjuvant chemotherapy, and place a statement as concurrent radiosensitization as standard. We also wanted to support the use of available and advanced radiotherapy techniques, including standard use of IGRT. And in the last 2 topic areas, node-positive disease and variant pathology, which we acknowledge is evidence-light, we saw the consensus statements as an opportunity to support decision-making in these evidence-light areas and support teams in making the most appropriate decisions for individual patients where we appreciate evidence is lacking. So in other RCR consensus statements, for example, breast and lung, there's been demonstrable improvements in evidence-based care. And this is the hope with the RCR muscle invasive consensus statements. We hope these statements will be a practical stimulus for the Uro-Oncology MDTs to reflect on their own pathways, ultimately to provide optimal, streamlined, patient-centred care with the ultimate ambition to improve outcomes. So thank you, Nicky. That's the end of my presentation. I'll stop sharing.
Thank you so much, Mohini. So we'll go on to Lydia, who's going to talk about patient impact. Thank you very much.
Thank you, Nicky and Mohini. My name is Lydia Makaroff. I'm the Chief Executive of Fight Bladder Cancer and the President of the World Bladder Cancer Patient Coalition. So what did we do? How was Fight Bladder Cancer involved in these RCR consensus statements? Well, we sat together and we found topics where evidence was limited, as Mohini said, and then we identified areas of agreement and disagreement and spent a day or so discussing these to find consensus. And I'd like to talk about some of the 4 consensus statements that I believe will have a big impact on patient quality of life and patient outcomes. So the first one, which I'm delighted to say had unanimous support, was that every hospital should have a named clinical nurse specialist with a special interest in bladder cancer. And unfortunately, at the moment, we do see so many bladder cancer patients who do not know who their clinical nurse specialist is or their allied health professional is who has a special interest in bladder cancer. And one of the things that Fight Bladder Cancer offers are free contact cards as well. So if you're a clinical nurse specialist, allied health professional, if you want to be able to make sure that your patients can contact you, we produce free contact cards, and you can order them at fightbladdercancer.co.uk/contact. And they also have our contact details on them as well, so that your patients can get 24-hour support. Another one of the consensus statements is that we should offer multiple opportunities for patients and their loved ones to talk about treatment options. So not just once, but whenever there is an opportunity, whenever we're having discussions with patients, let's talk about treatment options as well. And if you want to give them any reading material to look at before or after these discussions, you can also find that at pipebladdercancer.co.uk/treatments as well. But if we are really committed to joint decision making, then we need to offer multiple opportunities for these discussions. The third is that we should use tools like FactBL. This is one of the tools that is recommended in the consensus statement to ask questions about quality of life, for healthcare professionals to have deeper conversations with patients about the quality of their life. So you can go to facet.org and you can download the FactBL toolkit, which includes questions like, do you feel close to your friends? Do you like the appearance of your body? Are you interested in sex? It also asks questions about bowel movements, about urination, about stomas if they have them. And so sometimes using a tool like FactBL can help us have these sometimes difficult conversations and work through a checklist that we know has been validated. So I would really encourage all health professionals to use a tool like FactBL to have deeper conversations about quality of life. And finally, one of the consensus statements was that we should consider palliative radiotherapy for people in pain, people who are experiencing bleeding, people who are having side effects or effects of their cancer that could be alleviated by radiotherapy. So even if these people are not suitable for curative radiotherapy, we should still consider them for candidates for palliative radiotherapy if this radiotherapy can help make their final years or final months or final days more peaceful. And you can find more information and resources about end-of-life care and end-of-life options at pipebladdercancer.co.uk/terminal. So finally, I think one of the fantastic aspects of these new RCR consensus guidelines is it lets us reflect on our own practices, and we can look at these consensus guidelines and we can work towards them. So as Mohini said, let's all work together as a multidisciplinary team to providing better person-centered care for all.
Thank you so much, Lydia. That's great. So we're going to move on now to Nick James, who is an expert on chemo, radiation and bladder preservation. So thank you, Nick.
So yes, so I'm talking about optimizing radiotherapy for bladder cancer, and just a little bit of data on, oh, what's this doing? Sorry, it's trying to play itself. About the age distribution of bladder cancer. So bladder cancer, a substantial proportion of patients are diagnosed over 80, around a quarter of them. And the red arrows on here show you the median age at diagnosis in various series. So BA06 and SWOG 8710 are two big neoadjuvant chemo trials. So this shows that the median age in those was in the mid-60s, so well below the peak age at diagnosis. There's a number of big surgical series that I picked the biggest one, or one of the biggest ones, with over 1,000 patients in it. And you can see the median age for that is around 67. And so again, well below the peak age at diagnosis. So what you can conclude from both of these is that the data on the adjuvant chemo and the data on surgery don't really apply to the majority of patients we're seeing in the clinic. I've also highlighted two trials that I'll show you a little bit of data from. BC2001, which is a trial that I led, which looks at chemotherapy in addition to radiotherapy, and a second trial called Beacon, also a British trial led by Peter Hoskin, which looked at radiosensitization of nicotinamide and carbogen. And you'll see the results of these two trials are very consistent with each other. Now, so the take home from the sort of general overview is that surgery and radiotherapy data relate to quite different segments of the population, and the patients the surgeons are seeing and operated on are really a subset of the whole thing. And age and fitness is important in making surgery decisions, but for the older end of the age group, I think there's a decision around whether you do any treatment or palliative treatment or radical treatment. And I think mostly the answer is that people are being undertreated. So in terms of key phase 3 studies, there's loads and loads of studies showing that you can safely combine a whole range of different drugs with full dose radical radiotherapy. There's 3 key randomized phase 3 trials that I'd emphasize. The first was a very old trial now, published back in 1995, looking at cisplatinum given us a really high dose. And when we looked at this trial, the results were very interesting because the recurrence rate was halved, but the platinum dose ruled out at least half of my patients, if not more, because it was just very high. So we designed a study using much lower toxicity drugs, 5-FU and mitomycin, and the trial after phase 1 and the phase 2, we started the phase 3 in 2001, so again, a long time ago now, and published the results of it in 2012. Now, a second trial started around the same time using hypoxic cell sensitizers. So nicotinamide is the vasodilator. Carbogen is a mix of carbon dioxide and a high concentration of oxygen. The idea being that you dilate the blood vessels, you get more oxygen into the tumor, and that should make the tumors more radiosensitive. So the Beacon trial reported initial results in 2010. And so what you've got on the left is relapse-free survival, and on the right is overall survival. And you can see that on both endpoints, outcomes were improved by around 15% overall, and with really very acceptable toxicity. The BC 2001 trial, which I led, slightly more complicated design in that we had 2 randomizations. We randomized to chemotherapy or no chemotherapy, and we also had a radiotherapy volume randomization, which was optional. The radiotherapy volume randomization looked at reducing the dose to uninvolved bladder, and in essence, I think my take-home message from that was that there wasn't really a good enough radiotherapy kit around to adequately test the question, because we couldn't see differences between the experiment and the control arm, but we saw big differences between the chemo and no chemo arm, which I will show you. So the first is adding chemotherapy. This is the clinician-assessed toxicity, and I picked the 6-month endpoint, but all of the endpoints are the same. So pale blue is radiotherapy only, with the sort of magenta color is with radiotherapy. So you can see that adding 5-FU and mitomycin as a cocktail of the 2 things, the mitomycin as a single dose and the 5-FU as an infusion weeks 1 and 4 of the radiotherapy, had no impact at all on the clinician-assessed toxicity. So the majority of patients report very low levels of toxicity. This is post-treatment. And there was nothing to suggest that adding chemotherapy increased the toxicity of the mix. And in fact, what we found when we looked at this was patients who did get side effects on the combination ended up having a reduced dose of the chemotherapy, but still got the full dose of radiotherapy. So basically, you can fine-tune the chemo to keep the toxicity constant. So that's clinician-assessed outcomes. The second thing, and this is a pooled data set of both the arms, because again, there were no differences between the control arm, the radiotherapy only, and the experimental arm, radiotherapy plus chemotherapy. And what you can see, this goes all the way out to 5 years, is that on the physical well-being, there's a transient deterioration in the patient-reported outcomes during treatment. So this is taken at the end of treatment. So that's when it's at its worst. By 3 months post-treatment, 6 months into the study, they're back at baseline. You can see that for some things like emotional well-being, it actually went up even on treatment. So patients responded to being on treatment by feeling better than they felt before they started treatment. Functional well-being, as with physical well-being, drops a bit during treatment but rapidly recovers. And you can see these patient-reported outcomes then remain stable all the way out to 5 years. So, and there were again absolutely no differences between radiotherapy only and radiotherapy plus chemo. So basically the long-term outcomes from radical radiotherapy with or without chemotherapy are very good in terms of patient-reported outcomes. It's a very remarkably non-toxic treatment. So in terms of the outcomes, the primary outcome was local regional control, which is either invasive recurrence in the bladder, non-invasive recurrence in the bladder, or regional nodal assessments. And you can see we've got a substantial reduction in local regional failures, the dark blue, the blue line versus the dotted line. And that was driven almost exclusively by a near 50% reduction in invasive control. So these are the recurrences that kill you. They were halved roughly by adding the chemotherapy. So you've got a treatment with virtually no extra toxicity with a 50% reduction in recurrence rates. So coming back to Mohini's data that only 40% of patients are getting this or a similar treatment, we're clearly missing a massive opportunity to improve outcomes for our patients. The cost of recurrences are so high, salvage cystectomy, things like this, that the cost that preventing the recurrence is easily paid for by the cheap chemotherapy. So there's the health economic arguments stack up in favor of doing it, the clinical arguments massively stack up in favor of it. So not doing it, you are really doing a disservice to your patients. In terms of other key secondary outcomes, you reduce metastases by 25%. You reduce the need for salvage surgery to take the bladder out because you've had a recurrence in the bladder by half. So you can see that 90% of the patients in this are surviving long-term with no need for any further bladder surgery. We also split this up into 4 different groups, whether they'd had neoadjuvant chemotherapy or not, and whether the surgeons thought they'd resected all of the tumor or left the residual mass behind. So I'd just like to focus on this group here. So these are patients who are not fit for neoadjuvant chemotherapy, who had a residual mass post-surgery. So often these patients get only palliative radiotherapy. So roughly you'd expect an outcome like this. So you can see that 40% by 3 months, there's only 40% relapse-free by 3 years out. And you can see the improvement is over 20% absolute by adding the chemo-RT. So this is a group that often gets palliative treatment, and these data very strongly support the opposite, giving these patients radical treatment, because you're going to get a huge improvement in their pelvic control rates if you do so. So although the messaging around palliative therapy is important, I think the messaging around radical therapy is even more important. You can deliver it with really acceptable toxicity and get big improvements in outcomes. If we look at the patterns of relapse, what we can see is that a substantial proportion of these patients still relapse with metastatic disease, and that remains a problem, and that requires either systemic chemotherapy or palliative care, depending on how fit they are. But I think of the patients who relapse in the bladder, 2 out of 3 relapse with non-invasive disease if they do relapse in the bladder, and these can be salvaged with relatively simple intravesical therapies. A minority relapse with muscle-invasive recurrences, and these are the ones driving the salvage cystectomy that you see here. So the conclusion of all of that is that the benefits from adding chemotherapy to radiotherapy are preserved all the way out to 10 years of follow-up. So you get a durable benefit, and you get it without a significant penalty in terms of clinician-assessed toxicity or patient-reported outcomes. So basically, you can deliver these better outcomes without really inconveniencing the patient at all, compared to just giving them radiotherapy alone. And the benefits are substantial in all of the subgroups, including the least fit patients that we included in the trial. And the other important thing is the median age of the patients in the trial corresponds to the median age of patients in the general population. 20% roughly of the patients in the trial were aged over 80. So these results are very definitely applicable to the older patient age groups. So that's my last slide. Thank you for your attention.
Thank you so much, Nick. That's very persuasive data that you've demonstrated there. It now gives me great pleasure to introduce Vish, who has joined us, I believe. So thank you very much for racing from the operating theatre to our webinar. Vish is a consultant urological surgeon, and he's also an executive member of the British Association of Urological Surgeons, with a special interest in bladder and other urological cancers. So thank you very much, Vish. Welcome to our webinar.
Thank you, Nick. And everyone, sorry, just got delayed because of this was unplanned theatre list. So yeah, I've been really, happy and quite good engagement with this consensus statement, and it's been really good to work with the team led by Mohini and Nick and Lydia and rest of the team to produce this fine document. So from surgical side, I think it is very good in terms of setting out the standards in terms of the diagnosis and the staging for the cancers. So the first and foremost is when the patient is referred to with the visible hematuria, it is mandatory that we should, most centers should offer a CT urogram, ideally prior to the transurethral resection of the bladder tumor. And if in case the other staging tests which are essential for these patients is CT of the thorax, which should be done before if they are diagnosed with a muscle invasive bladder tumor. For bladder cancer, FDG PET is not an ideal, so it should be just considered in a selected group of patients only. MRI is being quite widely used in a few centers, and there are few trials coming in to see whether MRI could be used itself for the staging. So we're trying to get the staging tests. And the other point, what one should consider, and we felt that it was probably, and it was most members of the committee agreed that repeat staging is essential if the delay in treatment is beyond 8 weeks. So that is needs to be done in most of the centers where if there is a significant delay. This will help to streamline the diagnostic and the treatment pathway. So we felt that that's probably essential. Next slide, please. Yeah, so the next bit is from the TURBT. We felt that there was no general agreement in terms of what sort of stuff should be included in terms of for all the discussion at the MDT. So one is clinical and radiological the staging must be done. So in patients with muscle invasive bladder cancer, so they should have a full radiological staging, including CT chest, abdo-pelvis, and CT urogram to rule out any upper tract disease. The TURBT should it should include all the size, number, location of the tumors, and extent of resection, and any evidence of carcinoma in situ. For patients undergoing radical chemoradiotherapy, this is very essential. And with the new advent of TMT, this may be quite, for a solitary tumors, this may be more important. Most centers do record the renal function, but weight and height and performance status and comorbidities are essential before staging purposes, which we have started including the performance status and comorbidities for the last 1.5 to 2 years. Previously, it was discussed essentially on the clinical parameters. So we felt that these parameters should be discussed for the diagnosis and staging. Nearly around 30 to 50% of our patients are, at least in our locality, around 80 years, so 75 plus. So we felt that functional assessment, including the frailty assessment, should be offered. I know a couple of centers where they clearly have a frailty assessment by the elderly care team and the pre-op assessment team. So that should probably, it may be better to consider those things. Yeah. Thank you. Next one. This was quite important. I think Lydia has addressed in her talk. Consultation should be jointly possible with the oncologist and urologist. Most of the centers do offer this. On occasions, if the patient prefers to have a multiple consultation, it would be good to offer that. And we felt that that is essential, at least to discuss the options with the CNS or advanced nurse specialist who has a special interest in bladder cancer. So it would be good to have more data on this as we go along this, introducing this consensus statement, see how many centers have a dedicated specialist nurse for the bladder cancer. All the options, including neoadjuvant chemotherapy, surgery, and radiotherapy, most centers do discuss that. And in patients who are fit to have a neoadjuvant chemotherapy, it should be discussed with the patient, with the oncologist. And I strongly believe in prehabilitation, and we feel that especially with the elderly population and poor, health, initial build and the health. Prehabilitation should be considered. That shouldn't delay the treatment, but that should be given for all the patients with going for radical treatment for bladder cancer. Thank you. Next slide, please. What sort of follow-up protocol we should use? There's a standard guidance in most centers. We offer and having a 6 and 12 month and then annually up to 5 years. And following that, usually it's a functional statement only, and it was unanimously agreed that all should consider about offering CT of the chest, abdomen, pelvis. In patients with muscle invasive disease with the nodal positive, we may consider earlier scans depending on the patient's condition and the status for having further treatment. Following radiotherapy, they should have a cystoscopy every 3 to 6 months for the first 2 years and annually up to 5 years of the end of the treatment of the radiotherapy. In general, the late treatment effect and survivorship issues have to be addressed, and they should be offered to patients during the follow-up period. Thank you.